Michelle. And by the way, Michelle is a good friend of mine. I worked with Michelle, gosh, since I don't want to date us, a few decades now, but is one of the world's experts on LP-A. She's going to educate us all about it today. She's running a massive trial, seeing if this is really lowering LP-A. Will it improve outcomes? So, Michelle, help us with this educational gap. Help us understand that 20% of the population out there has an elevated LP-A. Very few of them know their number. And tell us what we can do about it. So, welcome to Baim Grand Rounds, Michelle.
Thanks so much, Mike. And I think actually your story was perfect for sort of phrasing how we think about LP little a,
That's what we do in
because
Grand Rounds, right? We present a case, right?
because one of the most common questions I get is why should I check my LP little a? But it really would reshift or reframe how you think about your own personal risk. I think if you knew that your levels were elevated, I think it's helpful that you're sharing your story because it encourages others to get tested as well. So let's see. Hopefully, you're seeing my slides here. So, lipoprotein little a, I've titled this talk, The Risk Factor That's Hiding in Plain Sight. These are my disclosures. And we'll start off with just some of the basic concepts. I know that there are some of you on this call who are very familiar with lipoprotein little a, but for others who are less familiar with the concept, what we're basically talking about is an LDL-like particle that includes ApoB, that is covalently bound to apolipoprotein little a. That's the key differentiating factor. And you see I've highlighted here this area called Kringle 4 type 2 repeats. That is an area on apo little a that is very heterogeneous between people. And I'll show you on the subsequent slide why this matters. We know that there are several different isoforms that exist that encode this region for Kringle 4 type 2 repeats. And that's what's being shaded here in yellow. In fact, there are more than 40 isoforms that exist. Now, there's an inverse correlation between the length of that chain and your LP little a concentration. So we know that if you have a very long number of Kringle 4 type 2 repeats, that you tend to have a lower LP little a concentration. So I'll walk you through that just a little bit further. People generally have two different copies of an apo little a allele. And each
Michelle,
one,
is it, if I went to CVS to get my blood tested or Quest, can do commercial testing? Can we know how long my chain is, or is that a special like lab thing?
special lab thing. But
Oh,
yes,
well.
but it is knowable. And so we've been
Hmm.
doing a little bit of research as well, just sort of looking at the apo little a allele size in and of itself, and how some of these novel therapeutics respond based on apo little a allele size, and some of the racial and ethnic differences that exist as
Uh,
well. So
yeah,
it's
there's
interesting.
more black people have an elevated LP-A, but are they different in terms of these chain lengths?
Yeah, that's a great question, and it's an interesting one because, as I mentioned, there's that inverse correlation where generally people who have shorter um, uh, Kringle 4 type 2 repeat regions have higher LP little a concentrations. And yet, actually, when you look at it by race, it's not always quite as reliable. So, we know that actually, for instance, people of African or Black descent that they actually have more intermediate range length in the Kringle 4 type 2 repeat region, despite the fact that they also have higher LP little a concentrations. So it's not sort of lockstep always in terms of just the length, that inverse correlation. There are some other determinants at play as well.
Do we know how it's related? Does this affect its relationship to events? I mean,
Um,
we know the level of LP-A is related to events, but
yeah,
the,
there's some studies to suggest that the length of that Kringle 4 type 2 repeat region is independently associated with the risk of cardiovascular events beyond just knowledge of your LP little a concentration. But the data there are mixed. So not reliably, but some data to suggest that perhaps that matters in and of itself.
but if longer means lower LP-A,
Mhm.
is longer bad or is shorter bad?
Well, generally, you want to have a longer Kringle 4 type 2 repeat region.
Mhm.
That tends to translate into having a lower LP little a concentration, so ultimately beneficial. So most people have longer Kringle 4 type 2 repeat regions,
But independent of the LP little a level,
independent of the LP little a.
right?
Yeah,
Longer and shorter, how do they match up?
yes. So you'd still want to have ideally a longer.
Longer. Okay.
Mhm.
All
Yeah.
right.
So most people have two different copies of this little a allele, and then that therefore encodes the length of this entire Kringle 4 type 2, Kringle 4 region on your little a. And then ultimately it's the sum of these two different alleles that leads to your LP little a concentration that you measure in your blood. Now, primarily it's genetically determined, but there are a few little other non-genetic influences that I'll touch upon. But I'll also just highlight that the type of assay you use matters. This often comes up because, I think more and more people are measuring their LP little a, but they're not always aware of the fact that the mass and the molar assays are really yielding completely different values. And, one key thing to know is that you can't directly convert the results between a mass and molar assay. And that's because of the fact that there's that variable size of little a. So on the left-hand side of this slide, I'm showing you a scenario where you've got the same number of particles, but with variable masses. And then on the right-hand side, you might have a different number of particles, but with similar masses. And overall, the research is indicating that risk is likely better captured by the number of particles, so measured with nanomoles per liter. But again, it's really quite vastly different numbers that you get through these two different assays.
And to get into trials, do you use the nanomoles per liter or the milligram per deciliter number?
It depends on the trial. So the as we'll get to later, the Novartis trial, their entry criteria is based on mass, so based on the milligrams per deciliter assay. Most of the other trials have shifted towards the particle count, the molar assays, including the olpasiran trial that I'm involved with.
Hmm.
So it's
Interesting.
it's believed that upward of 90% of your Lp(a) concentration is determined by your genetics. But I find it's actually interesting that there hasn't been as much conversation about the non-genetic factors that do influence Lp(a). We know that there's an inverse correlation with chronic kidney disease, where it can rise with lower eGFR. It may go down with liver disease. It may go up with hypothyroidism. And I'll show a subsequent slide just showing the effects during menopause. But it's also an acute inflammatory, an acute phase reactant. So you can see a transient rise in LP little a, albeit typically a slow one after an acute inflammatory process. But as you said yourself, Mike, I mean, I think one of the key things is that lifestyle changes such as diet and physical exercise typically have limited or no impact on LP little a. And that does create a conundrum for people like yourself who find out that they have high LP little a values and then are struggling to know what to do with that. So despite the fact that it's genetically determined, I find this interesting that this is some work that we did from the phase 2 program of olpasiran, but looking strictly at the placebo group. So we had the opportunity to measure serial values over the course of just a little bit more than a year. And we hadn't had a lot of opportunities like that in the past to have that many serial LP little a values. You can see that for any individual patient, each line indicating one person, that there's a fair amount of variability. Now, granted, these are all individuals who have high LP little a values at baseline. So, we're starting with people who are perhaps in sort of the higher echelons of starting values. But, about a quarter of patients had more than a 25% change from their mean on at least one visit. And more than half of people had an up or down swing of 50 nanomoles per liter or more. So, I think making some argument that LP little a values may bounce around, so to speak, more than you may think.
Well, mine's like the atomic clock. It never really changes. So
Maybe that's because you're very predictable in terms of your
I
patterns.
guess.
But the distribution of LP little a is, of course, well described, although primarily across, Western populations. We have less population data, although it's now continuing to grow on a global basis. But it's very skewed, as you can see here. Most people live with very low LP little a values. And I'll highlight that because, I think there are a lot of questions that come up about whether or not lowering LP little a to very low values is safe. But I think making the argument for that, we know that most people live quite happily down with LP little a values that are down below 20 nanomoles per liter, for instance. But there's a very long tail. So we have people who have really quite astronomically high values. And those are the people right now, who we sometimes see in clinic, we sometimes see in the hospital. They're presenting with premature coronary disease. We're really hoping to find options, therapeutic options, to provide them clinical benefit. But as you noted, we know that there's marked differences by race and ethnicity, and some of that has to do with those genetic determinants that we were talking about for that Kringle 4 type 2 repeat region. And Black persons in particular, on average, have threefold higher values than those who are white or Western ancestry. South Asian also have higher average concentrations. So I think that that's quite notable because even when you look at the distribution, the bell curve within a Black population, it's not as skewed as we see here on the figure on the left. In fact, it's a little bit more centered in terms of it not being as clear of a skew. But importantly, the relationship between LP little a and the risk of major adverse cardiovascular events is consistent irrespective of race and ethnicity. That's at least what the most of the evidence suggests. And I highlight that because, if we thought that perhaps the relationship with MACE risk took off at a different value, for instance, for those of Black descent, then, perhaps that would sort of attenuate some of that risk. But I think it underscores the fact that, for people in particular of Black and South Asian ancestry, that this might be largely an under-recognized risk factor. I had mentioned that there are these changes that have been described in LP little a over a woman's lifetime. We know that LP little a can rise up around the time of pregnancy, and also around the time of menopause, we see a rise. And what's interesting as well is that it's been described that that rise might be blunted or attenuated with hormone replacement therapy. So, I think there's a lot that we're still better understanding about this hormone relationship with LP little a. And whether or not part of the excess and risk that we start to see in cardiovascular events for women in their postmenopausal years may in part be explained by this rise in LP little a concentration. So digging into it a little bit further, certainly it's been decades of work. I'm just highlighting some of the earlier findings from Paul Ridker's group from the Physicians' Health Study, describing the relationship between lipoprotein little a and the risk of myocardial infarction. And now that's been broadened to a wide degree of different disease states. This is a little figure that I think nicely sort of underscores some of the relationships that have been observed based on observational evidence by looking at the relationship between LP little a and calcific aortic valve disease, MI, heart failure, ischemic stroke, PAD, cardiovascular death, as well as atrial fibrillation. These are data now dating back to 2009, pooled data across several different studies showing a log linear relationship between rising LP little a and the risk of non-fatal MI and coronary death, as well as ischemic stroke. But as one might expect, no relationship with non-vascular death. But I think even beyond the observational evidence, we have a growing number of Mendelian randomization studies that really support the causal role for LP little a and coronary heart disease. The genetically predicted LP little a is strongly associated with the risk of developing coronary heart disease in one's lifetime.
Michelle, has anyone looked at LP little a years?
LP little a years, probably,
Like we look at cholesterol years, LDL years, once
yeah,
you
yeah. No, it's
get over 4,000, you're in trouble.
No, that's an interesting. I'm now starting to picture the figure that I could create. So I think it's a good point. I wouldn't be surprised if somebody has, but not that I know to to my best of my knowledge. But somebody can chime in during the conversation if they know otherwise. But despite the fact that there's some observational studies to suggest that Lp(a) is associated with risk of venous thromboembolic disease, the genetics don't as strongly support that. So this is looking at numbers of Lp(a) increasing variants. And as you can see, as you increase a genetically predicted Lp(a) based on these particular genetic variants, that there does not appear to be as clear of a relationship with venous thromboembolic events. So I think that the jury still remains out on that particular point.
Do you have the simultaneous plot of Lp(a) and LDL from a Mendelian randomization perspective? A
Um,
multivariable kind of look at that?
Yes, I don't have it in this particular talk, but yes. And I'll talk a little bit further as well, that it's interesting looking at the effects, for instance, of PCSK9 inhibitors on both Lp(a) and LDL, and, how the correlation is not quite as strong as one might expect. So looking at this Manhattan plot GWAS study, looking at predictors of aortic valve calcification, aortic valve replacement, you can see that the LPA gene really jumps out here. And so that relationship is well described, and that also provides some optimism on the horizon if novel therapeutics ultimately are able to modify the trajectory of aortic valve disease. These are some data that Nick Marsden, as well as others, had published a couple of years ago now. But looking at the magnitude of the relationship with risk for non-Lp(a) ApoB, so just a regular LDL particle, an ApoB particle, versus Lp(a), which of course is that ApoA component bound to ApoB. And suggesting that on a per particle basis, these were two separate studies that were published around the same time, suggesting that Lp(a) is more atherogenic on a per particle basis than regular LDL cholesterol. There have been a lot of people looking into some of this in terms of what would the mechanism be. Sam Samikas and others have been doing a lot of work looking at oxidized phospholipids and the fact that they're preferentially carried on Lp(a) particles, and that might be part of that sort of pro-inflammatory mechanism by which Lp(a) confers atherogenicity. But I think that for most people who have low Lp(a) values, this becomes less relevant because even though it's more atherogenic on a per particle basis, you just don't have that much Lp(a) in your blood. But for those at the other end of the spectrum who have high Lp(a) values, you can appreciate that there becomes very important to consider their Lp(a) concentration and think about strategies to lower it.
Can I ask you a question, Michelle? I mean,
Yeah.
a guy like me, my ApoB is actually fine. It's good. And my CRP is like next to nothing. What
Mhm.
is the interaction? I mean, mathematically, statistically, is there an interaction term in terms of risk between these things? There's a one-way
Yeah.
interaction of Lp(a) and ApoB, but is there a three-way or higher order interaction among some of these things, including the inflammatory axis?
Yeah, Mike, your question's an important one because there has been a lot of interest in whether or not you sort of need a two-hit hypothesis. So, is Lp(a) enough on its own to confer a lot of excess risk, or do you need to have inflammation at play? Do you need to also have regular LDL, ApoB elevated? So I will admit that the data have been mixed along the way, but by and large, the most recent evidence that we have that have pooled data across several studies suggest that you don't need to have both present, so that there's no clear synergistic effect. Sure, they both provide additive effects in terms of increasing risk, but it does not need to have one to have the other, so to speak, for each one to be a player.
So additive, not synergistic. Interesting.
Correct.
Okay.
Yeah, based on the weight of the evidence. Because I
Hmm.
will say that there have been some studies along the way that have suggested perhaps a synergistic relationship, an interaction, as you put it. But most recently, the largest data sets suggest not the case.
Thanks.
One of the questions that comes up, though, is there any physiologic role for Lp(a)? Why do we have it anyway? Most animal species actually don't have Lp(a), and is there any reason we need to have it around? Is lowering it too much going to be a problem? The only thing that's been observed so far is this relationship between very low Lp(a) concentrations and risk of diabetes. So that's been suggested across a variety of studies. Sam Yamura was one of the first people to describe this from data with the Women's Health Study, but it's been described across a variety of different data sets. We also looked at this as well, just even within the Fourier trial of evolocumab, and saw that same relationship between lower Lp(a) and risk of prevalent or incident diabetes. Now, there's a little bit of controversy in the space about whether or not it's a causal relationship, a little bit of a chicken and the egg question about whether, in fact, low Lp(a) may be, whether or not, sorry, in the setting of diabetes, whether or not that may influence Lp(a) concentration on its own. And so it's not really reflecting, it's not a causing driver, but rather it's a reflection of the cardiometabolic disease state. But I think one of the questions is why are most physicians still not measuring Lp(a)? You can see here on the left that the trends in Lp(a) testing, so it's really been taking off, but it's still a very small number of people. When you look at the height of that blue bar, you're still looking at a very small percentage of individuals who are having their Lp(a) tested. And that heat map on the right is interesting just in terms of the fact that it's very regional in terms of where it actually is being tested. We know that there's certain lipid specialists and preventative cardiologists who are very keen on testing it. But there are many regions within the United States where it's not routinely being tested. So, I think I'd like to make the argument, though, that when it comes to Lp(a) testing, that ignorance is not bliss. Many of the consensus groups now support measuring at lipoprotein(a) at least once in all individuals. And in particular, I think the strongest arguments can be made for those who have premature ASCVD, a strong family history of ASCVD, and also those who are so-called statin resistant, who have persistently elevated LDL cholesterol on lipid-lowering therapy. And that's because, your estimated LDL cholesterol, part of that is Lp(a). Because it's a calculation, and Lp(a) particles would come into play. So, since statins don't lower Lp(a), so-called statin resistance would be another reason to check Lp(a) concentration. So, I think the million-dollar question, though, is really why? Well, and that's a common question that's asked, but I think to the point that you nicely laid out at the beginning, Mike, is that it changes how you think about your own cardiovascular risk. You would consider more intensive risk factor modification, perhaps earlier initiation of treatments. Family cascade screening may also be relevant. And then also now in this era of so many ongoing clinical trials, one could consider somebody for participation with one of these studies. And I think that it's notable. This is a nice figure that was provided within the EAS consensus document that was most recently published in 2022. But as you move from left to right, just sort of showing a traditional risk calculator in terms of lifetime risk of developing cardiovascular disease. But I think when you incorporate Lp(a) into that algorithm, you can see what a profound difference it can make in terms of lifetime reclassification of risk. Somebody who you thought was in a much lower risk group may ultimately be shifted quite into much higher risk group. And you would therefore, I think about whether or not to perhaps initiate a statin earlier in someone's lifetime, for instance. And that's currently, of course, in the absence of having any novel therapeutics that directly lower Lp(a).
So, Michelle, if you put a number on it, like how often would it materially change your prescribing, do you think? What percent of patients?
Well, I think this, maybe it doesn't get to the percentage point.
I see, but it shows a grid.
Exactly. But
Okay.
yeah, it's a grid, but it sort of gives you a similar type of concept in terms of just shifting people from one group to the next. This was also provided within that EAS consensus document, but I think it conceptually introduces people to how you might think about incorporating Lp(a). that if you knew somebody's Lp little a was elevated, despite the fact that they're in a lower risk group, you might still think about either lifestyle interventions and or drug interventions earlier in the course of their lives for both primary prevention and then also considering more intensive um, escalation of therapy for those in secondary prevention as well. But one of the challenges, as you had outlined, is that we currently don't have established therapies that are very effective for lowering Lp little a. This is showing, many of the therapies that are currently out there. And you had noted statins, statins, if anything, have been described to sometimes raise Lp little a. We still think, though, that the benefit of the statins likely outweigh any of this rise in Lp little a that can be seen. But of course, it's a little unsettling, for somebody like yourself, if you start a statin, you see your Lp little a rise further. Understandably, that's not where you want it to be going. With the PCSK9 inhibitors, we know that there's on average about a 20 to 30% drop. There's a wide degree of variability. PCSK9 inhibitors are not, they don't have a label indication for lowering Lp little a, but it is something that has been observed. And then for some, they turn to apheresis. That's another option, but of course, highly invasive. And even though it can lead to a large acute drop, time averaged changes are relatively small. So, all of these
Michelle,
different
what about GLP-1 inhibitors?
GLP-1s don't have a large effect. No, I think where there's a lot of interest has been in particular, though, with the CETP inhibitors.
Hmm.
Because the CETP inhibitors can actually lead to quite a large drop in Lp little a. Of course, they're not currently available, but
Hmm.
some of the data, for instance, that are growing with obicetrapib, are quite interesting in terms of seeing somewhere, around a 40% drop in Lp little a, which is quite interesting.
Wow. Wow.
There's a lot of interest too in this question about whether or not aspirin, so whether or not LP little a might be useful for helping to identify people who would benefit from aspirin in primary prevention. These were some data that now, more than 15 years old from the Women's Health Study, suggesting that carriers of a particular genetic variant that confers higher LP little a, that these individuals appeared to have their excess risk, so to speak, that it would be conferred with LP little a offset by being on aspirin. But then that risk was sort of brought back down to the non-carrier level. But at the same time, this was a relatively, there were a small number of major adverse cardiovascular events in this study. And a lot wasn't done in this space for a while, but this became another topic of conversation again when data from Esprit sort of showed similar findings, looking at this one particular genetic variant and showing that in the placebo group, who were not randomized to aspirin, that carriers of this particular genetic variant that confers higher Lp(a) were at higher risk, but that was not as clearly evident in the aspirin arm. But I think it's confusing that the data. Sorry, I would say again, a space where the jury is still out. We're not routinely recommending aspirin for patients with higher Lp(a), but I think that there's still a lot of intense interest in this space. When it comes to PCSK9 inhibitors, we had looked at this within Fourier. We showed, consistent with the other PCSK9 inhibitors, between a 25 to 30% median percent change. Now, the absolute change was relatively small at only 11 nanomoles per liter, but that's in part because it was a patient population who at baseline had low normal Lp(a) values. But to your point, Mike, I think it's interesting that there's a lot of intra-individual variability in response. These are just looking at folks in the evolocumab arm. And even though the median percent change was a 26.9% drop, you can see that people are all over the map in terms of how much there was a percent change, with some people even having a rise in their Lp little a despite use of a PCSK9 inhibitor.
I'm in that zero group, you know, nothing
Yeah,
happened. Yeah.
no, I know, unfortunately, right? Um, And then, when you look at the scatter plot here between the percent change in Lp little a and the percent change in LDL cholesterol, you might have thought that the two would be very lockstep in terms of response to evolocumab with how, you'd think that one correlates very strongly with the other, but you can appreciate that the scatter plot is suggesting that this is a little bit more all over the board than one might expect at first blush.
That's why I was asking about the Mendelian simultaneous LDL and Lp(a) hazard ratios adjusted because it looks like they're very independent. And when you look at CETP and LDL, they were independent.
Yeah.
So it'd be interesting to look at that.
And it gets a little bit to this point, Mike, as well, the sort of concept of dual goals, right? Should we be thinking about LP little a and LDL cholesterol as acting along completely different axes, even though both contain ApoB particles? And I think it is interesting that within Fourier's, you can see that there was this, that those who had achieved low LP little a as well as low LDL cholesterol were at lowest risk of events. And in the presence of both, those individuals were at highest risk. One of the challenges that has been put out there for the phase 3 programs is how large of an absolute drop in LP little a do we need to see for that to translate into meaningful clinical benefit? And a lot of work has been done based on the Mendelian randomization studies, but they've sort of yielded vastly different estimates, and that has been a real challenge. But if we think about, of course, data from the cholesterol treatment trialists, showing quite reliably that a 1 millimolar drop in LDL cholesterol over about 4 to 5 years reliably translates into a 22% relative risk reduction when it comes to major adverse cardiovascular events. Well, what is that number that we need to see for LP little a to see that same clinical benefit, that same 22% relative risk reduction? And you can see with the box here on the right that range is estimated anywhere between 66 to 101 milligrams per deciliter or 140 to 217 nanomoles per liter, roughly. So that's a wide range and it's a large value. So this is why the phase 3 programs of these novel therapeutics have really had to study those with the highest Lp(a) values, because if you need to see that large of a drop, you really need to start with people who have higher values than that at baseline, in order for that to be your average observed drop in value. So let's pivot to those therapies. A lot of them work through the concept of RNA interference. Pelacarsen is the furthest along in development. It's the antisense oligonucleotide. It targets the apo(a) mRNA strand within the hepatocyte and targets it for degradation. There are some small interfering RNAs. I've included those who'd already reported out phase 2 testing, but they have this RNA-induced silencing complex. So they work through a similar concept of targeting that apo(a) mRNA strand for destruction. The only difference is that this RNA-induced silencing complex allows for it to have repeated mechanism of action. So there's less frequent dosing that's required, just because it will continue to go around, and I'll show some data to that extent. These were the phase 2 results for pelacarsen, the antisense oligonucleotide. It was seen that there was up to an 80% drop in Lp(a), with dosing that was studied every week to 4 weeks. They've selected every 4 weeks for the phase 3 program, but showing, I think a very impressive result in terms of Lp(a) lowering. I talked about some of the work that Sam Semikis had done studying oxidized phospholipids with the hypothesis that this might be perhaps the main mediator by which Lp(a) confers its atherogenicity. And what's nice to see is that with pelacarsen that you see a robust drop in oxidized phospholipid species, both on ApoB as well as on Apo(a). And there's also this reduction in transendothelial migration that of monocytes that's also been described as well with pelacarsen. So the Horizon trial, the good news here is that the phase 3 outcomes trial, Horizon, is the results are expected midway through this year, or second half of this year is how the sponsor has phrased it. So We're, of course, eagerly looking forward to hearing those results. This is a patient population with established cardiovascular disease, including MI, stroke, and PAD, and everyone has an Lp(a) greater than 70 milligrams per deciliter. So they used the mass assay there. Olpasiran is the program that I've been involved with that's been sponsored by Amgen. It's a small interfering RNA, as I noted. You see here just within the hepatocyte that once it's brought into the hepatocyte, it forms that risk complex, specifically targeting the apo(a) mRNA strand, targeting that for destruction. And then when you don't have the apo(a) around, you can't assemble that Lp(a) complex. These are the results from the phase 2 program that studied 4 different active doses of olpasiran versus placebo in those with ASCVD and an Lp(a) greater than 150 nanomoles per liter. We saw a dose-dependent effect in terms of reducing Lp(a) concentration with more than a 95% drop in Lp(a) for those on the higher doses. And this is the administration every 12 weeks, sort of showing nice chronic suppression over that time without much fluctuation. I found this figure to be helpful as well. Just when we think about some of these individuals who have really sky-high Lp(a) values, if you look at the x-axis, this is the baseline Lp(a). You've got individuals with 400, 500 nanomoles per liter at baseline. Now, those higher doses, as indicated with my giant arrow there, is showing now what they're able to achieve on the y-axis with the higher doses of olpasiran. I mean, look at that. It's like they start at 500 nanomoles per liter and they get down to virtually zero with their achieved Lp(a) at 36 weeks.
That's
So it's
very
really quite
impressive.
impressive.
Very impressive, Michelle.
Right, and it's interesting, and of course it has raised some people to ask the question. Well, wait, do we need to have a little bit of Lp(a) around? And I think, of course, ultimately that's what these clinical trials are going to be well powered to demonstrate. But I think, as I mentioned before, we know that, for instance, people who have genetic variants that confer low Lp(a), and most of us who walk around who have low Lp(a), aside from that diabetes risk that I had mentioned, we're not aware of any kind of clear safety concerns from low Lp(a). So, of course, it'll be important to see within the scope of larger programs.
Are you doing any neurocognitive tests? Are you obviously you're looking at new onset diabetes, but how aggressively are you looking for some of these issues?
Yeah, neurocognitive, there hasn't been any particular concerns in that regard. It's not the same relationship that we think exists, that or had been hypothesized to exist, I should say, with LDL cholesterol. So no, there's not a dedicated neurocognitive sub-study, but there is a lot of rigor for capturing diabetes events and any changes in glycemic control as well. So that is going to be an area of interest for the phase 3 programs. And what's also interesting too is that, this has been described, this I'm showing data for olpasiran, but this has been described for all of the novel therapeutics in development in this space. But there's this drop in LDL cholesterol and ApoB, somewhere between a sort of 15 to 20% drop that's been described. And you can see here that it's actually quite independent of the dose, which is interesting because at first people thought, well, of course, if you're dropping Lp(a), that would, I would expect that to drop your ApoB concentration. But that's not necessarily true. If you take a step back and you think about it, these drugs are knocking out ApoA translation. But what is the fate of that ApoB particle that originally was destined to be bound, so to speak, to ApoA? And this was some of the work that we did. Andre Zimmerman was a fellow in our group, and he had done some nice work here. We tried to disentangle some of that. We're looking at the 3 different Q12-week doses here of olpasiran. And the height of the orange bar going from baseline to week 36 is the observed drop in Lp(a). So perhaps no big surprises there. Of course, ApoA is being knocked out. You expect that the height of the orange bar to drop. But the question is, why does the blue bar not proportionately grow all the way back up? Because you would expect that perhaps those ApoB particles are now just free floating around. They didn't find their dance partner, but they're still in your blood. But it does appear that they're disappearing, and there's interest in whether or not that's a decrease in production, a decrease, or sorry, an increase in clearance. That is an area of investigation. But some kinetic studies, I think would be interesting in that regard. Just like was described with pelacarsen, with olpasiran, we also looked at oxidized phospholipid species. Here, really seen a very robust drop in oxidized phospholipids with higher doses, leading to more than a 90% drop in these oxidized phospholipids. And I'd also mention the prolonged duration of effect of olpasiran. And we see that, as you can see, the last dose administration here at week 36. And then nearly a full year after that last dose, those on the higher doses of olpasiran, were still somewhere around about a 40 to 50% reduction in Lp(a) from their baseline values. So much as, similar akin to what has been described with inclisiran for LDL lowering, these drugs appear to have prolonged duration of effect when they're small interfering RNAs. Oceana Outcomes has completed enrollment. That is the phase 3 secondary prevention population for olpasiran. These are individuals with established ASCVD as defined by either prior MI or high-risk prior PCI, and Lp(a) greater than or equal to 200 nanomoles per liter. This study is still in the follow-up phase, but more than 7,000 patients were enrolled. And now we are also actively enrolling in the Oceana pre-event program. This is, again, individuals with Lp(a) greater than 200 nanomoles per liter or more who are at high risk for a first major cardiovascular event. So excluding those who have had prior PCI or prior MI or stroke, but looking at those who either have multiple risk factors or established athero without a prior event, and studying to see if there's benefit in this population as well. I just wanted to mention lepodisiran as well, another small interfering RNA that has also shown very robust effects. This has also now moved into phase 3 testing. I have a summary table on the last slide showing the different trials and sort of where things stand. But you can see, again, sort of around about 95% reduction in Lp(a) with prolonged duration of effect. Muvalaplin is interesting. It's an oral small molecule inhibitor. These were the phase 2 results, but it basically works by preventing the covalent binding of ApoB to the Apo(a) component. So it sort of disrupts the two particles, one from the other, and so Lp(a) can't be assembled. And using this intact Lp(a) assay, it looks like there's about an 80% drop or so in Lp(a) with this particular method of disrupting the covalent bind. So this is where we stand with the different programs. There is the Horizon program that I mentioned that is wrapping up as we speak, with results expected later this year. 2 ongoing trials of olpasiran, one of which is still enrolling. The muvalaplin trial by Eli Lilly is also enrolling, as well as a claim with lepodisiran. So I think it's an exciting space. We have a lot of phase 3 programs that are ongoing. And, I think everyone is sort of standing by with bated breath to see how the pelacarsen results look later this year. So in summary, I'll just wrap up by saying that I think there's a very robust evidence base to support a causal role for Lp(a) and coronary heart disease risk. But I think what remains unknown is really how large of an absolute reduction may be required to see meaningful clinical benefit. Also, we have observed through the years that the relationship appears to be strongest with coronary events. So whether or not there'll be as much of an effect, for instance, on reducing stroke is another unanswered question. But currently, as we await some of these novel Lp(a) lowering therapeutics that are now in development, really the strategy is towards traditional risk factor mitigation for those who are found to have elevated Lp(a) concentrations and are at higher risk. But, I hope you'd agree that I think that overall there's tremendous promise and enthusiasm regarding these Lp(a) lowering therapeutics that are in development. And they lead to such robust drops in Lp(a) and have such a pure effect towards targeting Apo(a) translation that I think we'll be in a very good position to sort of definitively answer the question about whether or not Lp(a) indeed plays a causal role in development of coronary heart disease. So I'll wrap up there, but I welcome any questions.
Michelle, that was absolutely spectacular. I'm not disinterested in this topic. I'm very interested in it. I think it's going to be interesting to see how all of you untangle the LP little a lowering from the LDL lowering from the ApoB effect and examine the causal nature of all this. It is a genetic disorder. Has anyone contemplated genetic therapies for this?
No, so very much so. And of course, gene editing is a very uh, interesting space that people are exploring right now. But LP little a indeed is one of those areas that's being explored. Because one could imagine, certainly if I think if these novel therapeutics prove to be effective and people are testing their LP little a perhaps more routinely at an earlier age, there might be appetite for thinking about a one and done type of approach towards wiping out your LP little a over a lifetime. So I think that it is interesting, right? Because usually with LDL cholesterol, one thinks about sort of that acquired lifetime risk, and there's so many dietary and other lifestyle factors that come into play. But in theory, one broadly speaking knows their LP little a from a young age. Now I mentioned the fluctuations, but I think by and large you're still not going to be dramatically shifting from a very low risk to a high risk group over a lifetime.
Well, there's a lot of things you can do in terms of risk factors to get your LDL down, but you can't do that with Lp(a). So the whole lifetime exposure thing with LDL, you can do some lifestyle modifications to alter that. Not all that effective. But with Lp(a), you're really kind of stuck. So if lower is better, perhaps longer is better. And I think, if this works, I think the next big question will be, when do you start? If it does work, uh, would you start this in someone in their 20s or 30s? I mean, if there is a risk of diabetes, factoring that in.
I think that a strong argument could be made for people with very elevated levels who have a strong family history as well, to start at an earlier age. As I think that probably many of people on this call have seen some individuals who have very high LP little a who present at a relatively young age. I mean, people in their 30s who are presenting with complex multivessel disease. So, I think certainly there'd be interest in, how to identify some of those higher risk individuals, whether or not you would perhaps think about other strategies such as, calcium scores or, other types of tools. Albeit, I appreciate that at younger age groups, there's been some question mark as to, how reliable it is for predicting risk. But I think that there is still going to be interest probably in using some of those additional tools to identify higher risk individuals. Now, even though, to your point, though, about diet and lifestyle, even though they don't directly modify LP little a, they reduce risk. So, I think that that's why we just need to think about overall, just still strategies to reduce risk, even though we're not making the LP little a number look prettier. It still, though, ultimately we think would benefit the patient overall.
We know that LDL lowering with statins, we know LDL lowering with PCSK9 inhibition makes your arteries look prettier. I mean, we know that you stabilize disease progression. Sometimes they may promote calcification. What do we know in terms of imaging studies with lowering Lp(a)?
Great question. Ongoing, so I think that there is interest in the questions you're asking in terms of, what types of modifications in coronary plaque might we see. So there are some, I think more focused coronary studies that are planned to look at plaque morphology.
Now we know Lp(a) is an acute phase reactant. If you're inflamed, it may go up a bit, but does elevated Lp(a), does it cause chronic systemic inflammation that may drive atherosclerosis?
Interesting question. And I think there's, gosh, with inflammation, I feel like there's so much we always don't understand. So, I will say I don't know with certainty. We have not seen, though, any kind of clear drop in inflammatory biomarkers with LP little a lowering therapeutics, for what it's worth. But nonetheless, I think that that's an area still of exploration.
I'm working with Clive Meanwell, John Maraganore on a PCSK9 inhibitor you give once a year. In an antihypertensive, you give once a year as a small inhibitory RNA. Any chance we could get there to once a year treatment with this kind of molecule?
I think so, and I know that there are companies that are sort of striving towards less frequent administration, and sort of what's that sweet spot? Is it once a year? I think people do like the idea that perhaps somebody could just come into clinic and be administered a therapy once a year. And as you know, even with inclisiran, for instance, that you still see that a full 12 months after the last dose, that you still have um, about a 20% drop in LDL cholesterol that's seen out at that later time point. And that's seen with olpasiran too. I showed those data. You still have a 40 to 50% dropout, 1 year after that last administered dose based on the phase 2 data. So I think there is interest in less frequent dosing, and that's being explored by some of the other therapies in development.
We got some great questions from Rick Keller in San Antonio. I was going to ask this. He says, in people with an elevated Lp(a), is there a hierarchy of event categories? Now we know there aren't as many strokes, maybe a lot more MIs, a hazard ratio 2.5-ish, stroke 1.5-ish, PAD 1.3-ish. Is that real? I mean, are you going to be looking at, I hope you are, because I really do think what we've always done, the the totality of events, the multiple event analysis, the time to any event analysis, and these frequent flyers. I'm sure that's pre-specified. I mean, is it a big part of your hierarchical testing?
Yeah, no, I think it's such an interesting question, right? I mean, sort of integrating all the different lipoproteins that we have, because of course now there's so many novel therapeutics in development in the triglyceride space, remnant cholesterol. I think greater attention being paid there. And that slide that I'd shown with the data, sort of looking at the atherogenicity of Lp(a) versus LDL cholesterol. I mean, I think to Rick's good question, one could think about sort of integrating all of our different lipoproteins and thinking about their relative atherogenicity. Then part of it then becomes their abundance, their relative abundance in the blood. And so for some people, it may matter more than others. But I think it's a nice vision that we could ultimately have that sort of all-encompassing risk calculator that really sort of more comprehensively assesses somebody's lifetime risk.
Sounds like we need LP little AI. I think that integrates all these particles, numbers of particles, particle sizes across all the different domains. Rick also asked a great question. In the spirit of more aggressive detection of atherosclerosis risk earlier in life, can an argument be made for Lp(a) screening in the pediatric population?
No, I think so. We know that there are some changes sort of in the pre-pubescent years. But it's much like LDL cholesterol. Is it worthwhile to know, for instance, if somebody might have FH? So in particular, for those who have strong family histories of premature coronary disease, or are known to have high Lp(a) in their family, that's where I think the strongest argument is made for pediatric populations. Right now, like, look, the reality is people by and large are not having their Lp(a) measured, period, let alone the pediatric
Well,
population.
unless they're
So,
at the ACC or AHA meeting, the line is around the block.
no, right? It's interesting how physicians are very interested to know their values now. Um, but so I think that it's been a positive shift that a lot of consensus groups have at least advised now towards measuring it once in a lifetime. That's, I think, a step forward. But generally, those are for adults once in a lifetime. But I think that arguments can be made to perhaps measuring the teen years for those who are particularly at higher risk based on known risk factors.
We've got Clyde Meckel, a member of the Brigham family in the past. Clyde asked, interested in your thoughts on the risk weighting ApoB using calculation based on the recent Jack paper, then using that number in an ApoA1B ratio. LPA ApoB has 6.6 times the atherogenicity. What are your thoughts?
Yeah, and I think it's a really interesting space. There's so much that's being done around this area, and Sam Samikas among has been working on this idea of ultimately these novel therapeutics are become available. Will we have to completely rethink how we measure LDL cholesterol? As I mentioned, the fact that Lp(a) is baked into an LDL cholesterol measurement based on, when you use an estimated value. So are we going to have to completely disentangle all of this? And I know that Samsung has developed an assay for sort of measuring more directly this kind of corrected LDL concentration in the blood. So, will we disentangle? Will we relatively weight things? How are we going to think about ApoB that is or is not bound to ApoA is an area of intense interest.
Again, the beauty of AI machine learning is it looks at things non-linearly and looks at higher order interactions among different variables. So this kind of thing may be well suited. How do you ask your doctor to get tested? Sam here is asking, how do I, if my family has a history of athero, how do I get tested? I went to my doctor, former chief resident, Harvard system, and said, I need my Lp(a) tested, and I didn't get a good response. So what do you recommend?
Now there's a lot more awareness than there was even just a few years ago. So I think by and large, people are becoming more aware of what Lp(a) is, but still the most frequent refrain is, well, what am I going to do with that information? And I think that the rebuttal to that is that, it would change how you think about your risk factor management. For you, it very much shifted your thinking, right,
Mhm.
Mike? I think that you're sort of a
I'm an
testimonial to
obese hunter-gatherer now. I have an LDL of 19.
that. It changed how you
Yeah,
approached your risk factor management. And I think that that's why we do it. And also now in the US, the insurance coverage is much better than it was before. It was confusing before. People didn't know if it was going to get covered, if you're going to be paying out of pocket. By and large, most insurers are covering it once in a lifetime now. And of course, that will continue to evolve, we expect. And in other countries, I think in Canada, most provinces have covered that under their healthcare system to be tested as well. So a lot of countries have moved towards coverage.
I'm feeling pretty good. Brenda Schramm says her PCP checked her Lp(a) without her asking, so that's a positive sign.
That is positive. But like you, Mike, I had to convince my PCP. I mean, this was years ago that I asked, but I think her response was something like, "Heck no." I'm like, "Well,
Not just no, but heck no.
no,
Yeah,
I did get a dramatic
yeah,
heck
heck
no."
no.
But
Yeah.
obviously, I somehow my role with the clinical trials was enough to convince her at the time that I needed to know my
I'll
LP little a.
humor you. I'll humor you and check it. Yeah,
But she did come back to me subsequently and said, since you asked me to do that, she said, I have actually now started doing it more routinely.
good.
So, I think it just takes, one person to start shifting the thinking. So, I encourage those who don't know to think about asking their provider because, again, wouldn't it change how you think about your own risk?
It does. I've been on a personal mission to educate people about this. So, well, Michelle, I thought I knew a lot about Lp(a), but turns out I didn't know as much as I thought. I learned a lot from you today. This was absolutely spectacular. Thank you for joining us. Good luck on your trial. I'm going to go out this week, hopefully get mine rechecked, see if I can fit into one of your studies. But I'm so glad to see you kind of spearheading the efforts here.
No, thanks so much for having me, Mike. I'm happy to talk on this topic. And I know there are many who joined the call who are actually even more informed than I am. So, thanks everyone for taking the time.
Thanks, Michelle.